Welcome to Facebook, live from Johns Hopkins Medicine. I'm Elizabeth Tracy. This is Head and Neck Cancer Awareness Week, and we are so privileged to have here with us in the studio two experts in that field, and I'm going to ask them to introduce themselves.
Sure. So I'm Rena Abrams. I'm a speech pathologist. I specialize in speech and swallowing disorders, specifically with patients who have head and neck cancers.
And my name is Christine Gore, and I'm a specialist in head and neck cancer surgery.
Thank you so much for taking the time to be here today. I deeply appreciate it. I'd like to start first by asking a question about head and neck cancers. It seems like there's an awful lot more head and neck cancer out there.
You're correct. The incidence of head and neck cancer is rising for several reasons, but we can expect to see more cases in the future.
I think we have a graphic we'd like to take a look at that describes this incidence or the number that are taking place. 70,000. Wow, that seems like an awful lot. Are you surprised by this number?
I'm not surprised. We know that in the last 2 decades, the number of head and neck cancer cases that are seen in the developed world is increasing. So it's not just a phenomenon unique to the United States. And projections suggest that those numbers are going to increase even further in the next several decades.
Are there populations that are disproportionately affected? Specifically, are men more affected than women? I think we have a graphic about that also. So, my goodness, way more men than women. Why is that?
It's true, and there are several reasons for that. You asked about populations at risk. Historically, head and neck cancer, or most head and neck cancers, not all, are related to tobacco and alcohol use. And historically, men have always used those substances at greater numbers than women have. But we also know that men are at a particular increased risk for reasons that are incompletely understood. But we do see more head and neck cancers in men than women, it's true. Not to say that women are not at risk, though.
There's a virus, human papillomavirus, or HPV, frequently abbreviated, that at least as far as I've been able to determine is also involved with head and neck cancers pretty often. Is that right?
It's true. HPV is the newest thing in head and neck cancer. I say thing because about 20 years ago we weren't really aware of its role in carcinogenesis or causing a head and neck cancer. It has always been known to be a causative virus in the development of cervical cancer. But in the head and neck, about 20 years ago, we started to see more patients who didn't have the risk factors of tobacco or alcohol use and who seemed to be younger, getting cancers that they did very well as a result of treatment from. And subsequent research has shown that this is related to the human papillomavirus. That is right now what's considered an epidemic. The numbers of HPV-related cancers is rising, and that accounts for the greatest increase that we see in head and neck cancer today.
Can you help me to understand how a viral infection might be related to the development of a cancer?
I don't pretend to be able to understand the exact pathogenesis, but we know that people that are exposed to the HPV virus, and that's most of us contract an HPV type infection in our lifetimes, and the majority of us clear it. But in some small percentage of people, the virus persists. And when the virus persists, after about a historically 10-year period, when we look to cervical cancer guidelines, an even smaller percentage of patients will develop cancer related to viral infection. I don't pretend to understand the reasons why that happens, but that is a known association.
Are there specific strains, because I know right now we have a vaccine against HPV that are related to the development of cancer?
Yes, so there are what are called high-risk strains of HPV. In the head and neck area, primarily it's 16 that is the most common strain of HPV virus associated with cancer. But there are some other high-risk strains too. And there are 2 vaccines available now. One covers 2 strains and the other covers 4 strains.
And would it be your guess then that when we give that vaccine to more adolescents that we're going to see a decline ultimately in head and neck cancers?
That is the hope. It has been shown in countries like Australia that the incidence of cervical cancer can be almost entirely eliminated in women because of early vaccination. And so our hope is that if enough people get vaccinated, we'll see a decrease or perhaps elimination of head and neck HPV-related cancers. But not only young people should get vaccinated. The current FDA guidelines are for anyone up to the age of 46.
Rena, let's turn to you for a second. What about HPV infection and rehabilitation of someone who's been treated for head and neck cancer?
Sure. So a lot of these patients that have head and neck cancers require some degree of rehabilitation, whether it be speech or swallowing or both. And one of the, I guess, good things about the HPV virus is that their prognosis for cure and survival is much better than the non-HPV related cancers. And so what that means is that the rehabilitation process is even more important because these patients are living so much longer. We want to make sure that they have what we call prehab, so they're getting rehabilitated up front.
And so there's no real difference then whether they have HPV or not in what you do for rehabilitation?
Correct, yes.
But really important to get rehabilitation.
Yes, very important. Yes.
Before we dive further into that topic, let's talk about treatment. Treatment frequently, of course, does require surgery.
Well, it's true that oftentimes a surgical procedure is required to make the diagnosis. Head and neck cancers can involve anywhere from the back of the nose to the opening of the esophagus. So all those areas need to be inspected for tumor development. And we always confirm a biopsy site, so you never want to treat somebody based on your assumption that that's where it's coming from. So some degree of surgery in the form of biopsy at a minimum is required. And then the treatment options consist of surgery, radiation, chemotherapy, increasingly immunotherapy, and these are given alone or in some combination, and the exact treatment recommendation is based on the stage, the site, and patient's goals and wishes.
Well, let's talk about that. So let's factor back even a little bit further. How is it that someone even suspects that they have a head or neck cancer?
There are some symptoms that are unique to the head and neck. We always worry about anybody with unilateral or one-sided ear pain, trouble swallowing, a change in your voice, difficulty swallowing, a lump in the neck. These are the most common symptoms, but the truth is, particularly with HPV-related cancers, the only symptom one may have is a lump in the neck. So we encourage everybody to get checked out if they feel a new mass or have any symptoms that are new referable to the head and neck.
Do you get referrals from dentists sometimes? Do they detect them?
Sometimes they do. A good dental exam will pick up oral cancers, sometimes in their earliest stages. So we never discount a referral from a dentist. They know what they're looking for.
Is there a familial component or genetic component to the development of these cancers?
There is one familial link in the form of a disease called Fanconi's anemia. People with Fanconi's anemia are at risk of oral cancers, usually earlier in life, in the teenage years. Fortunately, this disease is very rare. We're not aware of any other genetic link to head and neck cancer.
And how about staging? We hear an awful lot about what stage a cancer is. How is a head and neck cancer staged?
It's staged based on three things. One is the size of the primary tumor, and the primary tumor is somewhere in the lining of the tissues, the back of the nose, back of the throat, down near the voice box. So that's the T stage. The end stage refers to node status and whether or not there are any enlarged lymph nodes present and how big they are and how many there are. And then the M stage is for metastasis. Is it anywhere else in the body? An overall stage is assigned based on that combination. So it's primarily the size of the tumor and whether or not there's lymph node involvement.
Rena, after somebody has staging, diagnosis, treatment, that could be any one of these modalities, they come to you. Can you give me an overview of the kind of assessment that you do and how you develop a treatment plan?
Sure. So a lot of it varies depending on what the plan is, whether they get surgery up front or if they're getting radiation or chemoradiation or a combination. So usually if they're getting surgery up front, we evaluate them preoperatively with some type of swallowing evaluation. There's a few different types that I can get into if we have enough time later. But we are talking to them or counseling them really on what to expect after surgery as well. And then we usually see them post-operatively depending on what the surgery is and how extensive it is. And then for patients that are getting radiation or chemoradiation, again, we see them for a baseline evaluation, evaluate their swallowing, again, counsel on what side effects we would anticipate going through their treatment. And then we follow them usually for about 5 years after treatment because they can have changes post-radiation in their swallow function.
And even for 5 years, you would be involved in that rehabilitation.
Yes.
That's impressive.
Yeah, it's a long time. They get to know us well.
But that sounds like that's also some really great vigilance.
Yes.
Yeah.
Yeah. It's a lot of work that they put in, but it's worth it in the end.
One fear I've heard people express about treatment and subsequent rehabilitation of head and neck cancers is, oh gosh, am I going to need a feeding tube?
Sure. Yeah, that's a tough question, and you're going to get some variation dependent on where you're going, who your doctors are, you know. So from a surgery standpoint, again, it's totally dependent on the surgery and the extent of resection. So I think it's kind of impossible to answer whether or not people need that, but you know, we work closely with the surgeons to determine preoperatively if we think they'll need one, and also postoperatively. For patients that are getting radiation, our general kind of thought or knowledge is that we want patients to keep swallowing. So we encourage them to try to get through treatment without a feeding tube unless they need it. And that's, again, something that we do here. People may go to other facilities and find that they're recommending a feeding tube up front. And we know that by using those muscles, they have a lower risk of long-term dysfunction of those muscles. So using the muscles, whether it be by doing swallowing exercises, by continuing to swallow, are both two really important factors.
I imagine that can be quite troublesome, though, sometimes, isn't it?
Oh, absolutely. So radiation especially is very difficult, and you know, having a team of a multidisciplinary team to help work through that with it, the radiation oncologists, the dietitians, the medical oncologists, speech pathologists, the surgeons, you know, everyone needs to get involved in that care.
There's also a consequence of treatment sometimes that develops this stiffness of the jaw, trismus.
Mm-hmm.
How about that?
Yeah, so trismus can come from surgery, it can come from radiation therapy, and so again, we treat that prophylactically with the radiation patients, and then also reactively for radiation and surgery. So there are gentle stretches that people can do. There are devices out there to work on stretching the jaw. Basically, the earlier that it's caught, the easier it is to treat. So it becomes more of an issue if people let it go.
I love this concept of rehabilitation. Are there other things that people can do previous to their treatment that would aid in their recovery?
So aside from doing swallowing exercises and jaw stretches, that's, you know, that's again for radiation patients. Usually the surgical patients, they don't need to do anything before surgery.
Chris, would you answer that also? Are there things that people can do to try to make sure that they're going to achieve the best outcome that they can from their seat in the bleachers?
There are some things patients can do. If you smoke, quit. If you abuse alcohol, stop that as well, because both of those things interfere with wound healing after surgery. But also during radiation and chemotherapy, those things interfere with your tissues, handling the effects of radiation and recovering from that. And then I just want to second what Rena said about the swallowing therapy. Wherever you get your care, you should make sure that your team has recommended you see a speech and language pathologist. This is as critical to you as seeing a surgeon or a radiation oncologist, because the exercises that Rena prescribes are key in preventing late complications from treatment.
Is there a role for robotic surgery here?
There is. We actually do a fair amount of robotic surgery. The surgical robot allows us to see around corners, and it's not suitable for all cancer types, but where it's really shown is, or where it really shines, is in HPV-related cancers involving the base of the tongue, because the robot allows us to go take out that tissue while minimizing disruptions to normal tissue. So patients swallow pretty well. We've published our data that 95% of patients are home the next day eating on their own. They see Rena and her team afterwards for swallow therapy. But it's really remarkable how TORS has allowed us to still offer surgery to some patients and reduce the odds of needing chemotherapy when the tumor is suitable for TORS.
You both identified not just each other, but other professionals as really pivotal to your approach to a comprehensive strategy for managing people with head and neck cancer. Of course, all those folks are available right here at Johns Hopkins. And why do we need to come to an academic medical center to be treated?
So we know that outcomes are better at larger centers because of that team approach. I mean, we all meet together once, sometimes twice, sometimes more than that, every single week. And so I think just having that collaborative team to work through whatever issues each person is having makes it, you know, gives them a much better outcome and allows them to get through treatment easier.
It takes a team, it really does, because if you see a surgeon, you're going to get a surgical opinion, and if you see a radiation oncologist, you'll get their opinion. And what you really need is to have the entire team weigh in and decide collectively what the best options are. The other factor is that it really matters where you get your care. So we know that volume matters. Places that treat a high volume of head and neck cancer patients have better outcomes. And that's not opinion, that's fact. So it's very important to see a team that is knowledgeable about head and neck cancer, is aware of the role of speech and language pathology in rehabilitation and prehabilitation, that is aware of the importance of ongoing swallowing therapy during treatment, and really is up to date on the newest advances, such as using the robot when that's indicated, and some of the newer treatments as well.
We do have an event that's taking place here at Johns Hopkins at the end of this month we'd like to advise you about if you need to learn more about head and neck cancer and also meet with some survivors. On April 27th, as you can see, there's an event taking place here, and you are certainly welcome. Thanks to both of you for joining me here today. You've both been so informative, and I know what your academic schedules are like, so this was really a big gift. Thank you so much.
Thank you for having us.
Thank you. It's been a pleasure.